Hello everyone, this is Fatima. I'll go today over the Msk Nuclear Medicine lecture. So let's start. The first slide defines what's nuclear medicine and why it's important to use it in the Msk system. So to understand the definition, it's a physiological, metabolic, functional imaging, we need first to understand that when we use an image to diagnose, we can assess two parts. So first, we can assess the anatomy, and second, we can assess the physiology. Okay. So when we are using a modality to assess the anatomy, actually we are looking to the structure itself. So for example, when we are using X-ray or we are using CT, MRI, and etc., we are looking to the structure. When we use a modality to produce an image and to look for the function, we are assessing the physiological part. Okay, and how can we do that? Basically, we are using radioactive material and we are using pharmaceutical material. So together we call it radiopharmaceutical. To do that, the radioactive material, the whole idea for using radioactive material is to have a radiation that enter the body and then a specialized camera pick it up and then produce an image. So you can apply this idea to all the next procedure in any block or even in your practice. احنا بنستخدم radioactive material، مادة مشعة، وبنحط معاها ماتيريا تشبه العضو اللي احنا نبغاها تروح له. مثلا في البون بنحط فوسفيت فاميلي مع radioactive material عشان احنا نبغاه يتركز في البون. ليه احنا بنعمل كده؟ في البون سكان we are injecting the material intravenously, so it will go to the whole body. إيش الشيء اللي حيقول لي radioactive material you need to be concentrated in the bone to have something from the organ that you wanted to go to it that can lead the radioactive material to go there more than any other organ. This is the whole idea from the using a radioactive material with a pharmaceutical material. Okay, so it's a physiological, metabolic, or functional imaging, and we can detect the early changing more than the anatomical changing. So why we can do that? ليه احنا نقدر نكشف عن الأمراض أسرع من الموداليتي اللي تكشف عن الاناتوميكال في most of the cases؟ علشان لما أي تقريبا مرض يبدأ من molecular level and we are imaging the molecular level. So because of that, it's a good modality to early detection for the diseases, okay, affecting the MSK system in this case, okay? So, and from where we can get the radioactive material? Actually, we get the radioactive material from the periodic table, if you recall the periodic table. في هذا الليكشر هنستخدم التكنيسيوم، هنستخدم غاليوم، هنستخدم فلورين، هنستخدم انديوم. اوكي، هذا شكل الجاما كاميرا اللي احنا بنستخدمها. إذا كنتوا تفتكروا من الراديation safety, we already talked about the particles, type of the radioactive decay, particles and non-particles, alpha, beta, positron, and non-particle like photon like X-ray and gamma rays. So this crystal, we call it, a gamma camera has a crystal, pick up the gamma rays. Because of that we can give the name for it as a gamma cameras. I changed a little bit the order for the slide just because I found this more easier when we are explaining. So I'll send the lectures in the group if you want it also. So bone scan. لما نيجي نتكلم على بون سكان، نحن نقدر نقسم البون سكان ل whole body bone scan، ونقدر نقسمها ل SPECT. whole body احنا نتكلم على planner whole body or 3 phase و SPECT. PET totally different, like it's a different machine, different isotope, it's different. So here we can say PET. طيب أصلا يعني ايه planner imaging، يعني SPECT، يعني ايه SPECT CT، يعني ايه PET، يعني ايه PET CT، ايش يعني هذه كلها الكلمات؟ So planner basically يعني احنا بنتكلم على 2D imaging. هذه 2D imaging، بس اللي صار انه الكاميرا عدت واخذت صورة من فوق الين ما وصلت لتحت من قدام ومن ورا. هذا اللي صار في 2D imaging. هذه يسموها static بس انه بيغيروا الانجل حق الاميجينج. ليه اصلا بعد البلانر؟ طب كان اكتفينا بالبلانر، ليه احنا اصلا عندنا SPECT or SPECT CT؟ علشان احيانا لو مثلا خلينا نعطي مثال، لو انا في هذه picture we can say that I don't need to do SPECT. بس لو كان عندي lesion here and lesion here and lesion here وممكن lesion here، حتى لو عملت static imaging زي هذه برضو consider planner، ما حأقدر بالضبط locate where is the disease. okay, because of that the need for SPECT is sometime essential. why? because SPECT is a 3D imaging. اللي حيصير في SPECT انه الكاميرا حتلف حوالين البيشنت وتاخذ لي picture من كل الانجلز. so هذه الصورة اللي هنا SPECT CT. إذا تقدروا تلاحظوا إنه إحنا عندنا sagittal، عندنا coronal، عندنا transverse. we can actually locate any lesion بطريقة مرة accurate. عشان كده SPECT مهمة. متى نسميها CT؟ لما إحنا نحط مع SPECT CT على طول نسمي SPECT CT علشان أحيانا نبي نشوف الاناتوميكال بارت، لأنه SPECT بتوريني الفسيولوجيكال بارت، الCT حتوريني الاناتوميكال بارت. تمام؟ يعني ايه طب PET and PET CT؟ we have I think here picture for that, so I'll go to it. So if you can see, this is the PET and this is the CT. هذه الماشين حقت البات CT، هنا البات وهنا CT. هي أصلا a fused imaging which is so great because if we can see, this is only the PET. We see like increased uptake, but we cannot actually locate the vertebra, which exactly each like the radiopharmaceutical, if there is a lesion, I cannot locate it exactly just from the physiological part. So they developed a fused imaging, but this is the anatomical part and this is the fused. Look how amazing this picture, because we can like detect exactly where is the lesion. If we have a lesion, we can detect exactly where is it. علشان كده PET CT مرة قوية في التشخيص. طبعا على حسب إيش إحنا بنشخص. SPECT CT اختصارها Single Photon Emission Computer Tomography 3D Imaging زي ما قلنا، وإنه لو صار لها combine مع الCT حتصير اسمها SPECT CT. مثلا هذا another example، هذه هنا lesion عندنا. If you can see we cannot actually بس من هذه الصورة نقدر نعرف فين exactly this lesion، بس لما نحط modality تانية، modality تقدر تورينا anatomical part so we can exactly detect where is the lesion. So عشان كده مرة مهمة SPECT CT. PET اختصار ل Positron Emission Tomography، Positron Emission Tomography and CT part. So bone scan, we are talking about a common method for nuclear medicine. Like bone scan is so common in nuclear medicine, and also here remember when we talked already in the beginning that we are tagged the technetium with, which is the radioactive material combined with the phosphate family, those the phosphate family, and this is the explanation for the abbreviation for each one. So we use مادة مشعة technetium مع phosphate family علشان احنا نبغاها تروح للبون. طيب ليه احنا exactly اخترنا phosphate ما اخترنا another like material or another type of bond؟ لو جينا احنا نعرف حنرجع شويتان نقول انه إذا تفتكروا skeleton is made up of an organic compound and organic matrix like collagen and blood vessels, and the inorganic like calcium hydroxyapatite crystal. So we are actually want the radioactive material to stuck in this part. Because of that we used the PCP bond, and this is important علشان تركيبة العظام أخذنا شيء من العظام عشان يتركز الراديو اكتيف ماتيريال بالذات في العظم مو في أي مكان تاني. حيروح لكل الجسم بس نبغاه بعد كده أتليس يروح لمكان معين. وهذا explanation إنه إيش اللي إحنا بنسويه، إنه we know that the bone responds to injury and disease with increased turnover and attempt to self-repair. The physiological process can be imaged، وهذا اللي احنا بنسويه في nuclear medicine، ان احنا we are imaging the physiological part. So as we already said that bone scan is intravenously given, and the image time, like it takes time to image the patients, so I'll go over it right now with a scenario. We need to know that 25 to 35% of it gonna be excreted through the kidney. So if you see like the kidney, the bladder has a high uptake, so we can expect that because that's normal. It's gonna be excreted from the kidney. And for bone scan we are expecting also that the osteoblastic lesion gonna take a lot of uptake. Okay, so we have here 3-phase bone scan, 4-phase bone scan. I'm gonna go over all of that right now, just give me a second. And here 4-phase bone scan, because we got a question also about this. خلينا نعطي مثال على سيناريو. إذا إحنا جانا مريض في الديبارتمنت، هذا المريض جاي يسوي bone scan. Usually we interview the patient, we know the history, we know that it's correct order. يعني احتاج المريض يسوي هذا الأوردر عشان نجد حنوصل لنتيجة من الإكزام or not. Okay, after we make sure from all of that, what we do, we basically inject the patient with a small radioactive material and give the patient, this is in the whole body bone scan, give the patient from 2.5 to like 5 hours. It's depend on each hospital and the protocol that they are using it. So, and when the patient come back, we ask the patient to remove any metal, just because any metal gonna appear photopanic, and we don't want that. And then we image the patient from up until down. If the picture that we got normal or abnormal, but we don't need extra pictures, we don't need SPECT, we can say to the patient, you can leave, and we got all the information that we want. If the picture, like we have some lesion and we cannot detect, the radiologist may ask for more picture like SPECT, CT, okay, or even like static, like maybe we don't need actually to take a picture from all the angle. We need just to rotate the camera a little bit here or here and take a picture. So this is called statics. Okay, this is the first scenario. The second scenario, if the patient if one of the patient is coming for 3-phase. Okay, for 3-phase, we cannot inject the patient and let the patient go and then come back. No. What we are doing, we take the patient right away after interviewing the patient to the imaging room. And actually, if we want to image the hand, if we want to image the feet, it's depends which area we want to image. We're gonna set the camera and position the patient. And we're gonna inject the patient. Once we give the injection, we're gonna start the imaging. Why we are doing that? Remember, it's called 3-phase. 3-phase, the first phase, we want to see for the first phase how the blood flow to the region. Another word, or we can say like blood perfusion. Okay, the second part, after this gonna take just a minute. The second part, we're gonna see how the blood pooling, and what we are meaning by pooling. Pooling, we are actually detecting the how the capillary, like the interstitium, the balance between the interstitium and the plasma. That's what we are detecting in the second phase, which is called blood pooling or blood pool. The third part, we're gonna say to the patient, well, we're gonna give you موعد بعد 2.5 إلى 3-4 ساعات زي ما بروتوكول المستشفى بيقول، ويرجع البيشنت and we're gonna do a delay. الكل الهدف من هذه مدة الانتظار، احنا نبغى السوفت tissue clearance. هذا اللي احنا نبغاه، soft tissue clearance، لأنه حيكون عندنا كتير soft tissue. نبغى الراديو اكتيف ماتيريال تكون أكتر شيء في البون. لما نعطي المريض وقت، ف more activity gonna be excreted through the kidney، عن خلال هذا الشيء حنقدر يقبل لنا الكونسنتريشن حق الراديو اكتيف ماتيريال في البون أكتر، فنقدر من جد ناخد صور كويسة. لأنه لو ما أخذنا مدة كويسة وبان لنا soft tissue we cannot differentiate، الماتيريال بتروح لكل الباري. So that's why we are waiting. And here this is the picture again, and this is the so this is what planner, and it's a whole body bone scan. This is normal, and this is just like the area where they put the needle. Most likely it's happened when they put a straight stick, not IV. So that's what happened. And 3-phase, we need we need actually to put an IV because we are injecting and imaging. In whole body, we don't need. We can give a straight stick. Straight stick is like إبرة عادية. وبنحقنها ما بنحط IV. Okay, and here we are talking about the outlines. So we can image the tumor, infection, trauma, metabolic bone diseases, and a vascular necrosis, complex regional pain syndrome, and joint imaging. So I made a little of diagram. So in nuclear medicine procedure, there is a bone scan, and the bone scan divided to whole body, SPECT CT, and 3 phase. اوكي، عشان دحين احنا حنعدي على امراض كتيرة و different conditions، ف put this in your mind. Whole body, we are detecting osteoblastic activity, most likely due metastasis. اوكي، 3 phase لو لقيتوا مرض حيكون فيه له infection ولا fracture ولا حيكون فيه loosening to the prosthesis، حنكون في 3 phase. اوكي، حنقول على طول bone scan 3 phase. لو المنطقة ما حتبان لنا أو نحتاج ناخد angle مختلفة حنطلب SPECT CT. تمام، هذا بالنسبة للبون scan. So based on the indication we can know which protocol we can use. PET CT different. PET CT we are detecting osteolytic lesions. So and for the PET, actually it's not just imaging the bone, we can also image all other body organs. Okay, and there's an important note: chronic infection gonna be in PET. If you have a chronic infection, like a disease which has a chronic infection, it's PET, not bone scan or not 3 phase. Okay, so keep this in your mind, and now we're gonna go over the different conditions. First, tumor imaging. We know that tumor can be benign, can be malignant, and malignant can be primary and secondary. Okay, and infection, we know that acute and chronic osteomyelitis, because we are talking about the Msk system, diabetic foot, prosthetic infection. So here we said that if it's chronic infection, it's going to be imaging with PET CT, and this is just FDG, it's fluorodeoxyglucose positron emission tomography, the abbreviation for it, FDG PET CT. And trauma like stress fracture, splint fracture in childhood, sport injury, and metabolic bone disease like Baggett diseases, hyperparathyroidism, renal osteodystrophy, and osteoporosis, osteomalacia, and bone dysplasia. Okay, let's move. Msk tumor imaging. So for the tumor, most likely if there is a cancer in the breast or prostate or lung, it's gonna be spread. If they didn't detect it early, it's gonna be spread in the bone, and bone scan is a good modality to image that part. Okay, and it's good for staging, follow up, and it's sensitive. Like, we're gonna know that there is a disease, but it's challenging to know which exactly the disease. It's not that specific. Okay, and 30 to 50% of patients will have negative radiography, like for example X-ray, and positive bone scan, because we are, as we said in the beginning, we are detecting the molecular level, we are imaging the molecular level, so most likely we gonna detect if there is a disease earlier. And here, like a pattern for the tumor imaging. Okay, so we know that there is many kinds of tumor, and when we see like a pattern, this is the most characteristic that detected by the bone scan, whole body actually bone scan. High activity, multiple, random, variable size and intensity, photopenic. Okay, the lesion itself, it could be photopenic, and there is activity in the edge for this lesion. So bone scan, if there is like a tumor that can have this characteristic, we can detect it through bone scan. Like for example, there is other tumor, neuroblastoma, we cannot detect it by bone scan. There is another scan we can do it, MIBG, but not bone scan, not with technetium MDB. Okay, so it's when we are imaging the tumor, we need to know what kind of tumor, and we need to know كمان ايش الموداليتي اللي المفروض نستخدمها. مين كان يخلينا نشوف الإكزام ما هو correctly إذا كان في false negative or false positive. So false negative لو كان avascular lesion, it's gonna be like a photopenic and we cannot detect it. زي ما قلنا هنا احنا we are detecting the osteoblastic activity. لو كان عندي tumor وهي التومر اللي عندي هي pure osteolytic lesion, bone scan cannot detect it. إذا كانت خصائص التومر نفسها osteolytic احنا ما نقدر detect it with bone scan، ما حتبان لنا. ولو كان في low bone turnover مثلا زي كبار السن حيكون عندهم low bone turnover, and sometimes it's really hard to detect a lesion on them if they have another diseases also. مين كان يقدر يخليني أشوف كأنه في مرض وهو ما في مثلا metastatic disease like osteoarthritis, multifocal infection, multiple trauma؟ هذه كلها حتبين لي إنه هي hot area، بس لو أخذنا الهيستوري من المريض وعرفنا إنه عنده هذه الأمراض we can expect that we're gonna see this area, that this area it's like higher uptake in this area because like those diseases. Okay, and هذه صورة توضح فين الكانسر منتشر. هذه كلها النقط اللي شايفينها that has higher uptake, it's metastases in the bone. And here SPECT CT, so the negative predictive value is 89%, and it has a higher sensitivity and specificity for detecting the vertebral body lesion. Okay. For PET CT, okay, so for PET CT there is higher sensitivity and specificity than SPECT. Why? الراديو ايسوتوب اللي بنستخدمه في البات different than SPECT. PET is a positron emission، نفس الانرجي حقت المادة المشعة قوية، فحتى الصور والسبيشال ريزولوشن وكل هذه الأشياء تطلع أوضح في البات سي تي، بس مو كل الحالات نحتاج نستخدم فيها بات سي تي. هي detecting زي ما قلنا lytic lesion، so لو كان عندنا osteoblastic lesion ما حتكون sensitive لها، فأحسن حيكون في دي الحالة البون سكان مو البات. كمان نقدر نشوف منها الإكسترا skeletal metastasis diseases. So that's so good actually, like إذا في another disease we can detect it from PET CT لأنه we can image like soft tissue also. There is flare phenomena, and what is it? لو البيشن أخذ كيمو ولا hormonal therapy, the bone will act and it's gonna be hot يعني hot lesions يعني higher uptake, which is mean that actually it's responding to the treatment, and and that's usually we can observe it in like the 3 months after initiation of the treatment. So that's why flare phenomena. So it's important history. لو نعرف إنه المريض أخذ chemotherapy hormonal therapy هنعرف إنه ليه هذه كلها الأكتيفيتي طالعة، وهنعرف إذا هو أصلاً responding to the treatment ولا لا. فمهم الهيستوري. هذه FDG PET. So if this is just PET زي ما تشوفوا نقدر نعرف إنه في أمراض، بس exactly where is it, it's sometimes hard to detect it. Maybe in the sagittal view you can see that it's hard to detect. لما أضفنا له CT part شوفوا لو عندي هنا مثلا هذه الليجن أنا ما أعرف أقدر بالضبط أحدد فينها بالضبط. من يوم ما أحط بات هعرف فين الليجن بالضبط accurately. عشان كده بات CT مهمة إنك تضيفي two modalities فيها، واحدة فيهم تشخص ال anatomical part and the other the physiological part. Because of that PET is important. Primary malignant bone tumor, we are not good in detecting primary malignant bone tumor, so MRI is better than us in this case, and it's a modality actually of choice. What else on this slide? Yeah, we can see that lipoma and hemangioma we cannot detect it on the FDG PET scan. And why do you think that's? FDG is basically like you are putting a radioactive material fluorine مع بتحطوا له glucose. فلو عندنا hemangioma هي إيش؟ هي ما هي non-cancerous and tumor and it's made up of blood vessels. hemangioma ما راح تاخد الجلوكوز، ما حتاخده. حتى الليبوما ما حتاخده لأنه هي fatty tumor. Okay, so it won't take the glucose part in the PET FDG. هذا الكلام اللي كنا بنقوله من البداية. لو عندنا radioactive material مع إيش الماتيريال اللي إحنا حطيناها معاه، عشان كده يختلف على حسب الماتيريال اللي هنحطها معاها. It's gonna be taken from the organ that we want or not. Well, we need to know what we are actually expecting to see and the history, if there is any other condition that might like interfere with our scan or might like increase the uptake for the scan. هذه osteosarcoma زي ما قلنا انه شكلها مو حلو عندنا في bone scan، و الأفضل مننا في هذا البارت MRI. عندنا benign tumor، احنا مرة كويسين في detecting osteoid osteoma. and أول ما تشوفوا ده حتى ال whole body scan we can see it sometime the osteoid osteoma. لما تشوفوا osteoid osteoma حنعمل 3 phase، حنلاقي high blood flow، وحنلاقي focal hyperemia، وحنلاقي كمان intense uptake بعد الديلي. لما يصير أول ما نحقن المادة المشعة ونبدأ على طول نصور في الفلو حنشوف intense uptake. بعدين بعدها حنشوف كمان في البلاد بولينج في second phase hyperemia، وحنشوف كمان في ال third phase there will be an increased uptake يصير osteoid osteoma. حنلاقي في كثير من الكونديشنز الثانية إنه حنلاقي مثلا في 3 phases uptake، بس عشان كده الهيستوري مرة important. لو كان عند المريض مرض تاني أو إحنا إيش نبى نشخص على حسبه حنعرف is it good enough to use this scan or not. أوكي، هذه بس بتوضح إنه في ال X-ray ما كان باين، بس في النوكلير ميديسن باين. Osteoid osteoma. And if we have any infection، تفتكروا قلنا من البداية infections gonna use 3 phase bone scan. So هذه مرة كويسة الموداليتي والبروتوكول حق 3 phase عشان احنا كان distinguish between bone infection و cellulitis. لو كان عندنا first phase, second phase, 3 phase. first phase, second phase, 3 phase. اوكي، لو كان عندنا increase uptake في ال blood flow و increase uptake في second phase اللي هي ال blood pooling، وكان عندنا delay bone uptake، عندنا وصل انه يكون عندنا في البون uptake في delay imaging، خلاص هنقدر نقول انه هو bone infection. لو كان عندنا increased blood flow وكان عندنا increased blood pooling، بس لما نرجع لنا المريض ما في عندنا increase في البون uptake في الديلي، يصير احنا نقدر نقول ان هذه cellulitis. كده نقدر distinguish between both of them. متى نضيف 4 phase bone scan؟ احيانا لو كان مثلا ال soft tissue clearance في البيشنت مو عالي، زي مثلا لو عندنا diabetic patient ال soft tissue clearance عادة ما يكون عالي، ف we need to add a 4 phase and delay also have a delay imaging. So this is the blood flow, and this is the second phase, the blood pooling, and this is the third phase, which is the delay. Okay. ليه أحيانا نضطر إن احنا نضيف غاليوم؟ ممكن يعني كنا احنا ماشيين ان احنا عندنا تكنيسيوم، والتكنيسيوم حيروح مع يروح للبون مع عشان عنده فوسفيت فاميلي. ليه احنا احيانا حنضيف غاليوم؟ ليه احنا احيانا نضطر نضيف انديوم اوكسين WBC scan or technetium HMBAO؟ This is explanation for the abbreviation. ليه احنا بنضيف هذه كلها الاشياء؟ علشان sometimes طيب a 3 phase طلعت لي في كل الفيزز increase uptake، كيف I can distinguish؟ ممكن اضيف another. احنا نعرف مثلا اوكي عندنا infection، طيب الانفكشن هذا ايش سببه؟ على حسب سببه مثلا نقدر نضيف يا انديوم اوكسين WBC سكان، نقدر نضيف غاليوم سكان، على حسب على حسب احنا ايش نبغى نشخص او احنا ايش شاكين فيه عند المريض، نقدر نضيف another scan to be more specific and to know like the diagnosis for certain. هنا تكلمنا عن diabetic foot، also 3 phase bone scan. احيانا لو كان عند البيشن infection ولا كان عند البيشن another disease like Charcot's arthropathy, we cannot in many cases we cannot have a certain diagnosis. It will يعني حيكون عندنا شك إذا كان هل بسبب هذا الابتيك، هل بسبب إنه والله البيشن عنده infection، هل بسبب إنه البيشن عنده osteomyelitis، هل ليه هذا الانفكشن، حيكون عندنا شوية شكك. أوكي زي ما هنا تشوفوا هذه أول دقيقة من البلاد فلو. إحنا بنصور دقيقة كاملة 60 سكند، وبنشوف أول ما الانجكشن كيف بتدخل للدم. تمام إلين هنا هذه صورة توضح البلاد بولينج، وشايفين كيف عشان كده بنسميها blood pooling. It's literally look like that and this is the delay. ونقدر هنا نشخص إيش عند المريض بالضبط، زي ما هنا بيقولوا it's head of the second left metatarsal عنده osteomyelitis because of that. Okay. 3 phases very important in this case. Okay, prosthetic infection. We know that there is aseptic and septic loosening. And نبدأ بأول شيء نبدأ ب 3 phase. 3 phase ما وضحت لي كفاية، نضيف عليها غاليوم، علشان غاليوم لما نضيفه الأكيورسي بتطلع أكتر، نقدر نشوف information أكتر. لو أضفنا انديوم أو أوكسين أو WBC، إحنا نعرف لو في البون مارو إيميجينج إحنا نعرف إنه البون إنفكشن اللي حتكون في uptake عشان إحنا حاطين معاها white blood cell in the area. بس لو عندنا ممكن نشرح دي أكتر، بس بما إنه ما في information كفاية أو كتير عليها I'm not gonna go into details. بس the whole idea إنه إحنا نبدأ أول شيء ب 3 phase gallium، نبي نزيد الأكيرسي أكتر، ممكن نروح ل radio labeled with WBC. Either we can do technetium or we can do also indium. okay. هذه صورة توضح البون سكان، وهذه الصورة توضح الجاليوم سكان. الابتيك between the gallium and bone scan different. نفس الاكسكريتنج حيكون different بينهم، حيكون في خصائص وكاركترستيك كتير مختلفة، عشان كده أحيانا يكون مفيد إن إحنا نعمل جاليوم مو بون سكان. Prosthetic infection will actually not specific to use FDG, PET-CT and prosthetic infection. okay. بس لو كان it's very useful in the chronic infection. تمام. MSK trauma لو عندنا stress fracture، احنا نعرف انه stress fracture ممكن يكون fatigue وممكن يكون insufficiency fracture. so احيانا ال plain x-ray sensitivity تكون مرة low, just 15%, which is actually مرة low. في دي الحالة a 3-phase bone scan like it's a good modality, or it's the modality of choice in this case. and basically it's like لو كان في عندنا stress fracture في الساكرم حيبان لنا as a Honda sign زي ما بتشوفوا في الصورة. shunt splint, well shunt splint is not fracture. احنا نعرف انه shunt splint not a fracture، وحيكون عندنا البلاد فلو والبلاد بول almost always normal. بس حنشوف ديك الساعة كيف حيكون الابتيك في الديلي imaging، عشان we need to do like 3 phase، وهذا أهم شيء في shunt splint. في شيء هنا، ليه احنا قلنا عشان splint is not a fracture؟ لأنه اللي حيكون عندنا inflamed periosteosis. يعني ايش؟ هو condition أصلا يصير inflammation of the band of the tissue that surround the bone زي periosteum، بس ما هو fracture. عشان اوكي بيطلع لنا كده بس ما هو fracture. هذا الshunt splint. هذا child abuse. نقدر نسوي whole body scan لchild عشان الراديشن عليه حيكون أقل من احنا نسوي CT scan، وحيبان لنا أكتر لو حيبان لنا إذا عنده. it's a good modality to detect that. Metabolic bone disease. هذه كل metabolic bone diseases. and هذه classical feature اللي ممكن نلاقيها في الميتابوليك بون ديزيز. لو احنا هنا في شيء مرة مهم، لو احنا ما شفنا الكدني والبلادر لازم نفكر ليه هل البيشن، اول شيء نسأل هل البيشن عنده كدني، عنده بلادر، ما عمل اي عملية قبل كده، ما شالها، تمام، احنا متأكدين انه هو عنده الكدنيز وعنده البلادر. في دي الحالة we need to think about metabolic bone disease. اوكي، اذا ما شفنا الكدني والبلادر، لانه الطبيعي انه تبان في البون سكان. البون حيكون hungry انه ياخد كل الاكتيفيتي في الميتابوليك بون ديزيز، عشان كده that's the reason انه ما بان لنا الكدني والبلادر. زي ما انتم شايفين هنا هذا الميتابوليك bone disease characteristic as the picture showing. and Bagot disease, we need to know it's the polyostotic. We need to know that if it's in the vertebra, it's a Mickey Mouse appearance. If it's in the mandibular, we can see Lincoln signs or Lincoln sign, like here. So it's in the mandibular because of that, and the Mickey Mouse sign. And hyperparathyroidism, we can distinguish between hyperparathyroidism versus malignancy. And fibrous dysplasia, it's a monostatic, and sometimes it's a polystatic. And this is like the criteria. We need to go to X-ray first, then CT, then MRI. And we just need to know that in bone scan, it's a well delineated margin, okay, not like the primary malignancy tumor. So we, as you see first in the osteosarcoma, so we can see this, it's like the, it's delineated margin, okay. A vascular necrosis. So actually the modality of choice is MRI, but in 3-phase bone scan, we can detect it earlier. Like we can detect it in just like 27 hours versus MRI, they can detect it in 6 days. So it need to be progressed for the MRI to detect it. But in like 3-phase bone scan, in just 27 hours, we can detect it. And this is a vascular necrosis. Yeah, here we can see that this picture is just showing that there is no abnormality in the X-ray. However, this is an area of photopenia in the blood pool, and also we can see like in the delay bone scan, here the photopenia area in the right hip. So this is also bone scan, but it's just they changed the background to black. We can put the background white or black, or also we can also change the intensity. Okay, complex regional pain syndrome. So yeah, we need to know that there is like the pattern is different. They detect the disease early والبيشنت جاء سوى 3-phase bone scan، حيكون عندنا high blood flow وحيكون عندنا high blood pool والdelay uptake، الثلاثة حيكونوا عندنا فيهم uptake high. وهذه احنا حنسميها peri-articular uptake زي ما انتم شايفين هنا. لو كان they detect the disease late and حيكون عندنا normal or decreased blood flow and blood pool، بس حيكون عندنا delay affected. okay. And so just know that patient with a bone scan abnormality have a higher response rate to steroid therapy compared without bone scan. Okay. And this picture showing the 3 phases. So this is the blood flow and this is the blood pool, and here the delay. Okay, so if you can see like there is a soft tissue clearance, we can see here like the bone because the soft tissue got cleared. And here the joint imaging for 3-phase, we can use 3-phase and joint imaging, and also We can use gallium 67 and septic arthritis and early rheumatoid arthritis. We can use it after, like, if the patient start the treatment, we can use it after 6 to 8 weeks, okay, to like assess how the patient is responding to the treatment. And here it said that future detection, hybrid MRI. It's not future anymore because they كانوا زمان يقولوا إنه الفيوتشر حق النوكلير ميديسن إنه يسووا hybrid imaging between nuclear medicine and MRI. Actually, there is many سواها already، سواها في MGH، بس دحين بيشتغلوا على الريسيرش. لهم كم سنة كانوا على animals بيشتغلوا، بس دحين بدأوا يشتغلوا على actual patient. So, and this is new tracer for pets. زي ما تلاحظوا pet كلها فلورين. هنا في another tracer but on bone scan we are using the fluorine. And hey, yeah, thank you so much all for your question. I hope that I defined what is nuclear medicine and you understand well the SPECT CT, PET CT, so and bone scan and the 3-phase also. I got here a very interesting question actually. Why would tumor have an osteopenic appearance on bone scan despite them being more highly vascularized than the surrounding normal tissue? So this is a very good question. Thank you for sending this question. But first, to answer this question, we need to know what kind of tumor you are asking about. Is it benign? Is it malignant? Is it primary? Is it secondary? So it's very important to know what kind of tumor. And also bone scan, like, are you talking about the whole regular whole body or are you talking about PET CT? So if you are talking about whole body, so it will appear osteopenic in some of the tumors like neuroblastoma. Bone scan cannot detect that. The main reason for that إنه التكنيسيوم لما نحطه مع الفوسفيت فاميلي وندخله عشان يروح البون وإذا كانت معها التومر how it's react أو and how it's behave won't pick this tracer. على حسب أي kind of tumor هنحدد إذا البون scan gonna be osteopenic or not. Okay. في ال PET actually it detect the lytic osteolytic region, but in bone scan it detect more the osteoblastic region. And as we already said, if we have hemangioma, if we have, like, there is many kinds of tumor, some of them will appear will has like higher uptake and other will not. So it's depend which kind of tumor and which kind of modality we are using. I hope I answered your question. If not, please contact me. I'll be more than happy to answer your question. And thank you everyone for listening.